So I could actually really use Frank's slides, and you'll see that I have a lot of his slides actually in my presentation, because what he really outlined is there's no practical use for biomarkers in the adjuvant therapy right now, because it's all about stratification, clinical trials, etc. So clearly there's no role for biomarkers in the adjuvant setting. So we have played around, just to give you a little bit of background, we have 5FU as our mainstay, of course. We played around with this, and then, of course, went beyond 5FU, but very limited. There's not a single targeted agent that really made inroads into adjuvant therapies. And these targeted agents are the ones we normally associate with biomarkers. We're really limited to capecitabine, 5FU, and oxaliplatin. There's really no novel agent being tested even right now, perhaps with the exception of some trial that might come in the future with immunotherapy in the adjuvant setting. We're playing around with duration of therapy. So standard adjuvant therapy right now is FOLFOX or capecitabine, oxaliplatin, and fluoropyrimidines. And we know pretty much, every patient with stage 3 disease gets FOLFOX or CAPOX. And irinotecan, bevacizumab, cetuximab have failed. So, and we look at high-risk factors. When we talk about high risk, we actually at this point in time in clinical practice use clinical pathologic parameters. So you get out of your normal pathological report. These are data from the MOSAIC trial, and they actually help us decide which of these stage 2 patients we might actually characterize for adjuvant FOLFOX. Now, the purpose of a biomarker, and coming back to the basics, what do we really need to do in an adjuvant setting? It can help provide prognostic information to adjust the treatment intensity according to the risk. The other point is provide potential predictive information to really select individual therapies for individual patients. But right now, the choice of therapy is really fluoropyrimidine, oxaliplatin, fluoropyrimidine, or nothing. That's really what we have. There's no other choice. So do we really need a biomarker for this decision? A biomarker? And Frank has quite nicely shown that there is no biomarker for exactly this decision, fluoropyrimidine, oxaliplatin versus fluoropyrimidine versus no therapy. Exception, I give you one. MSI high in stage 2 colon cancer. And I think we've talked about this before. You know the clinical characteristics, right-sided tumors, female predilection, poorly differentiated tumor characterized by lymphocytic infiltration. These cells might be resistant to 5FU. There's some data, from retrospective analysis. They looked at, patients with MSI high tumors, the blue curve here, they have great outcome in stage 2, and not so much in stage 3, because in stage 3 things are not as prognostically perfect for these stage 2, for the MSI high tumors. But in whatever analysis you looked at in stage 2 cancers, MSI high tumors have great outcome. Here's the PETAC3 analysis, a very strong prognostic factor, positive prognostic factor. Even in the study that validated the Oncotype DX score, MSI high mismatch repair deficient tumors, MSI high tumors had excellent outcome. So you've seen actually, Chris showed the slide here, stage 2, MSI high tumors, great outcome, stage 3, same, perhaps a little bit better, but really not really deciding, helping us to decide about prognosis, and stage 4, same or worse than normal 2. Frank already talked about the pooled analysis. He actually co-authored at ASCO 2 presentations, PETAC8 and NO147, looking at pooled analysis of a lot of the molecular markers in the adjuvant setting. And I'll go through this real quick. MSI high tumors, proficient or deficient mismatch repair tumors in stage 3 are not necessarily prognostic. A little bit better. You see the trend is a little bit toward the left on this slide, but clearly not as profound as in stage 2. And for overall survival, clearly no outcome difference. When we talk about other potential biomarkers, okay, I gave you MSI for stage 2, but what about RAS, B600E, and CDX alteration? We'll talk about this in marker signatures. Let's talk about the KRAS and BRAF story. Again, this pooled analysis that Frank co-authored. He already showed you these data. This stage 3 colon cancer So we see that BRAF mutation and RAS mutation actually do seem to have a poor prognosis in time to recurrence, in overall survival, but mainly driven in overall survival by survival after recurrence. Once patients have stage 4 disease, this is where these biomarkers really shine, particularly the BRAF mutation and the KRAS mutation as a negative predictive marker for EGF receptor antibody therapy. And you can do multivariate analysis here, and you can tease out that BRAF and KRAS mutations really have poor prognosis. But does it change our therapy? You would still treat all these patients with FOLFOX anyway. We have nothing different than FOLFOX to counteract these poor prognostic factors. So it doesn't affect our treatment at all. You can do your KRAS analysis as much as you want, but does it really, would you treat a KRAS mutant and KRAS wild-type tumor different in the adjuvant setting? The answer is no. And actually, the data are not perfectly consistent. There are PETAC3 data where KRAS and BRAF did not correlate with outcomes in the adjuvant setting, at least not for disease-free survival and relapse-free survival. So the KRAS and BRAF data really don't help us in any way to decide on adjuvant therapy. What about CDX2? CDX2 is something Frank didn't mention. I thought he would, because the data are actually quite interesting, published in New England Journal this year. So CDX2 is a transcription factor expressed in intestinal cells, and is commonly used when you get your path reports of liver biopsies. CDX2 positivity is associated, this could be colorectal cancer metastasis. And we have seen some data emerging that the loss of CDX2 is actually associated with poor prognosis. Very interesting data coming from pooled analysis, just recently published in New England Journal. You saw they had a detection and validation set. This is a pooled analysis of stage 2 and 3 colon cancers, and you can see that the CDX2 absence was actually associated with poor prognosis, and this even made it into the New England Journal as one of the stories. Now, what about the interaction with chemotherapy? And it's a little bit difficult to see. So this is kind of CDX2 with or without chemotherapy. And the top panel is with chemotherapy, is stage 2. The bottom panel is stage 3. And you can see apparently the middle column here, the CDX2 negative tumors, they seem to benefit from chemotherapy. So how could this help us? In stage 2 colon cancer, and this is what I kind of pulled out a little bit to make it larger for you. So stage 2 colon cancer, CDX negative, they seem to need adjuvant therapy. This is one of those things we normally don't always do. Decide on stage 2 colon cancer, chemo, yes or no, based on CDX2. But I would caution you right now, look at the numbers of patients. We're looking at 3-year disease-free survival, and you have 8 patients in the analysis. So this is not solid yet. This is clearly not anything where I'd say, this patient does or does not need chemotherapy. This needs to be validated in future clinical trials. And Frank didn't talk about Oncotype DX. I personally do not use Oncotype DX in my clinical decision practice because we know that MSI high tumor mismatch repair deficient tumors do well. T4 tumors in stage 2, they do poorly. They need adjuvant therapy. And the ones where it really matters, the ones in between, the T3 mismatch repair proficient MSS tumors, it doesn't really distinguish a lot between those patients with good or poor prognostic factors. So bottom line is, and I think you'll all agree, that with the sole exception of MSI high in stage 2 colon cancers, which we all do anyway, there's absolutely no biomarker which will influence your treatment decision in the adjuvant setting. Thank you.